It's time to turn down the noise and tune into this special edition of News You Can Use. Your host is Dr. Nick, the incrementalist, a longtime innovator exploring incremental changes across various industries that can be applied in healthcare. Combining the powers of observation and real-world experience, Dr. Nick makes the case that innovations in healthcare can be accomplished incrementally, not just by moonshot events. Now, here is Dr. Nick.
Hello, and welcome to this week's special edition of News You Can Use on Healthcare Now Radio. Today, I'm talking to Joe Sardano. He's the founder, chairman, and CEO of Sensus Healthcare. And we're going to explore Sensus's technology and what they're bringing to the treatment of skin cancer. Joe, thanks for joining me today.
It's a pleasure, Nick. Thank you for having me.
If you would, as I do with all of my guests, tell us a little bit about your background and how you arrived here, because that's always a different story. And, you know, people end up with different reasons for what they end up doing. It would be good to hear a little bit about your background as it relates to this company.
Well, I appreciate that. My background was I've grown up in Canada, born and raised, and moved to the United States in the late 70s, and soon found myself with a Johnson & Johnson company introducing MRIs, the very first MRIs that were FDA cleared in 1980. That was quite an experience as we were going through that process. There were a lot of misconceptions because in those days it was called nuclear MRI.
That's
nuclear
right.
Magnetic
It
resonance.
was. I remember it well.
Yeah,
I don't want to be exposed to nuclear.
Oh, I know. And it had nothing to do with nuclear. These
Right.
These were magnetic forces that were very, very unique. And of course, we don't have to say what phenomenal history MRI has had in our healthcare industry today. And then to fast forward in 1999, I was working for General Electric Medical Systems, and I was given the task of introducing positron emission tomography, which was another revolutionary technology that has done a whole lot for everybody and really being the true diagnostic tool to identify cancer in anybody's body. It also is used as approved by the FDA for Alzheimer's and for Parkinson's. So very, very good technologies that I was privileged with bringing to the market. And it became my expertise over the 45 years that I've been in healthcare in introducing new products to the marketplace that either didn't exist before or previously did exist, but with newer technologies and newer advancements. So after bringing those big technologies and working with some very large companies like CTI Molecular Imaging, which was later bought by Siemens, I decided to do something on my own. I wanted to find out what might be out there that I could bring to the market that would help patients and physicians treat patients a whole lot better. And I wanted to stay in oncology or cardiology. And I really fell upon skin cancer. I was very fortunate to fall upon it because it affected my father at the time, who was in his 90s. And who had multiple lesions all over his body from spending as much time in the sun during his summer days working in the garden with his tomato plants and vegetables and fruits and everything else. And so in discovering and learning more about skin cancer, I found out that it really was an untouched market. It was being treated with a surgical procedure that was founded back in 1960s with Dr. Frederick Mohs from the University of Wisconsin. And at that time, when he discovered this, it was 1 in 1,500 people that had skin cancer. And the reason why he came up with this technique was the fact that they found skin cancer in much older patients, probably 65 and older, and their skin elasticity and healing potential was not as great as when we were younger. Therefore, it required a different technique for stitching it up once the cancer was removed. And so a patient would walk out, if they're walking in with a freckle, might walk out with 20 or 30 stitches in their face, but that was done so that they can heal properly. And it was a very good technique. And the technique I would relate it to much like a chain link fence. The more links in the fence, the stronger the fence would be. And so these stitches were links in that chain that prevented the skin or helped the skin heal a whole lot faster. And so in all of my other businesses, technology has come into these domains and has really done well in helping physicians. And nothing had come into this domain for skin cancer other than Mohs surgery for about 50 or 60 years. And the Mohs surgeons did a very, very good job in protecting their craft. They also made an awful lot of money doing it. Mm-hmm. And patients were very, very happy that they were able to do it. But in the modern age, people want choices. There were more and more skin cancers happening. Our patients, being older, were living longer, were having more skin cancer, and therefore there were more complications. And what we did was strategically, we went to the Mohs surgeons in the field and they said, how could this technology possibly help you? And they're the ones that said, we need this technology because patients are living longer, growing older, having more skin cancer. We can't do surgery on everybody. Okay, what were the reasons? Well, a lot of these patients have pre-existing conditions. A lot of them are diabetics. Therefore, they have a much higher chance of infection when we do surgery. The second thing is they're on beta blockers or blood thinners. Therefore, they have a tougher time of healing. It takes them longer to heal, which is natural as you get older. Therefore, we need to do something other than surgeries so that we don't have to take them off their beta blocker. Others were lower leg, scalp. They said these were ideal. And then, of course, 31%. We've all been out in the sun during our years out there playing golf, tennis, running, walking, whatever it is. Even if we wear a hat, we will have a red mark on the tip of our nose. Somehow the sun always got to the tip of our nose.
It sure does.
And so as a result, 31% of skin cancers are on the tip of your nose. And when they do surgery on the tip of your nose, they literally fillet your nose in half, take skin from your forehead, make it a flap, or from your butt.
Right.
And patients aren't happy with the result. And a lot of times they have plastic surgery post that surgical procedure and so on. So patients were looking for choices. They were looking for other things to do. Doctors were looking for other things that they could do with these patients that had pre-existing conditions. And so we learned from them that SRT, superficial radiation therapy, would be a good, viable alternative for them. And since that time, over the last 16 years, the company has grown, the number of procedures has grown, the number of patients that go to doctors that have this device are growing. And what we did was we went to the Mohs surgeons. They were the ones who bought this first. And these Mohs surgeons now were growing their skin cancer business because more people were walking through their doors because they wanted those choices. And the doctors gave it to them.
Okay, so lots to unpack there, limited amount of time, but clearly huge issue, long-standing treatment that, I think for the most part has been pretty successful. It remains the gold standard. It's surgical, it's interventional, and, much like many other areas in healthcare, we see this sort of dogma. This is how we do it. And, trying to bring about change is challenging because there's always resistance. And, particularly in the US system, as you rightly define, the flow of money and specifically income for these folks is, dependent on many of these specific procedures. So you're talking about a new therapy. Let's, if you could, briefly explain what it is and, what it brings to the table.
Sure. Well, one of the early on misconceptions was radiation. That was the big question mark. And superficial radiation therapy is not the same radiation that you would have for other cancers, like lung cancer, breast cancer, anything. Electron beam is a very aggressive radiation that goes right through your body, kills everything in its path, especially the cancer, tumors, and so on.
Yep.
Superficial radiation therapy is exactly what it is, superficial. It's topical. It only penetrates about 5 millimeters below the surface of the skin. And it only attacks the skin cancer while it leaves all the other healthy tissue to continue to grow and to survive. But it only kills the skin cancer, and then it dissipates. So it doesn't have any negative impact anywhere else on your body. And over the 16 years that we've had this, and quite frankly, this is an old technology.
16 years.
Yeah. Over the previous, this technology was really developed. It was called orthovoltage back in 1906. It was used for many other things,
Right.
but it was a dermatologist who developed it. So it's a much different radiation than electron beam.
Right. So the radiation decays quickly, doesn't progress through. To be clear, when you talk about beam and so forth, that literally goes all the way through. So, this three-dimensional construct that we now create for radiation therapy is incredibly significant because you're aiming those beams in ways to try and avoid critical organs and damage behind.
Correct.
What you're saying is that this is not actually damaging the tissues beyond the 5 millimeters that you describe. I'm sorry, I've got to ask this because I'm a geek, I'm a scientist. How the hell do they do that? Because that's actually intriguing to me.
Well, again, superficial radiation therapy, it's photon radiotherapy. And so the photons are much different than electron beam.
Okay.
And that
So this
the
is light. I mean, to be clear, photon is light.
Yes. So that's the distinctive difference between the two types of technologies.
Mm-hmm.
And again, dating back to 1906, when they developed this technology, it was used for many other inflammatory skin diseases. They even used it for acne. And it was very effective on a lot of things.
Mm-hmm.
But because they didn't have specifics or the machine wasn't designed for specifics, like, for instance, we have applicators. It's exclusive to our technology. We have patents on it, but these applicators direct the energy directly to the surface of the skin. There is no radiation outside of that area. It's all contained and it's directed towards the skin, and then it dissipates within the 5 millimeters of the skin. And usually, the squamous cell or the basal cells are usually within 2 or 3 millimeters of the skin. So we attack a very good circumference. We make sure that all the margins are taken care of. And that's one of the reasons for the ultimate success of superficial radiation therapy in treating skin cancer, on top of the no side effects like no cutting, no stitching, no bleeding, and especially no scarring.
Right. So, I mean, makes complete sense. As you think about it, and I want to make sure that the listeners understand when I say photons and light is part of a spectrum, and radiation therapy is on that spectrum. It's just in a different spectrum, even though we talk about it differently, we perceive it differently.
Correct.
Which tends to give us a different sense of understanding, at least in my mind. So, it's still on the spectrum. It's still part of that treatment. You've obviously develop this in a way that allows it to focus and treat. Let's talk about the comparison. So I'm a patient, I come in and, unfortunately they say the dreaded word, you've got X cancer, skin cancer, and, there's several forms, at least, 2 primary. How does it compare? And how should I make my decision? Because I think part of this is being informed. And, it's a little bit shocking to hear that this has been around for 16 years. But given that we take 25 years to get anything into mainstream medicine, this is doing well.
Yep. Well, informed consent, of course, is very important. And our company has spent a lot of time training and educating physicians on what this technology is about. And of course, it has to help their practice. It has to be able to provide them with the results that they're looking for with their patients. And of course, if you went to a Mohs surgeon to address a skin cancer and they didn't have anything else, then you knew what you were going to get. You were going to have surgery. But if you have a Mohs surgeon that has our equipment, now the conversation starts with the patient. And that's all the patients are looking for, is they want a conversation. They want to know what's best for them. And of course, the doctor, 9 times out of 10, will always do what's best for the patient, and they'll have that conversation.
Right. I mean, to be clear, I think this is a generic problem in healthcare. And, I've been heard to describe this, if you go and see a surgeon about your cancer, he'll want to cut it out. If you see a radiation oncologist, he's going to want to irradiate it. And if you see a medical oncologist, he's going to, give you chemotherapy. And that's been a real challenge. We've created the tumor boards and so forth. But from a patient perspective, This seems like it's a bit of a challenge, because if the standard of care and, everything, if I go and see somebody, how do I know that they're going to even think about this? And how do I make sure that I at least have that option and I can have that discussion if my dermatologist doesn't even have this in their armory?
Well, of course, the internet has facilitated a lot of that. And I think that as we do naturally now, when a
Hmm.
patient is diagnosed with something, either they directly or somebody in their family is going to get online to try to find what is the best solution for that patient, for their loved one, or
Right.
friends and family. But so that has helped tremendously in identifying this. And of course, we have many doctors. Most of our installations are with Mohs surgeons because they're the ones who recognized firsthand
Hmm.
that they cannot treat everybody with that hammer. They have to have the alternatives. And there are many, many patients out there that have skin cancers on a regular basis. And if you sat with someone who had skin cancer and had Mohs surgery, ask them the question if they'd like to have it again. 80% of skin cancers are on your head, face, and neck, and it's very scarring. And although many Mohs surgeons at the beginning would say, well, it's very easy for us in 2 to 3 hours to cut out the skin cancer and it's done. Well, it's done for the surgeon, but it's not done for the patient. Keeping in mind that these are older patients to begin with, mostly our seniors, they go home and they have to heal. And they're told, watch it when you take a shower.
Yeah.
Don't get
No,
it wet. Don't
it's
sweat. Their life is put on hold until the stitches come out.
don't
And
sweat, really.
yeah, and these patients take 20 to 30 days
Yeah,
before they
no,
heal.
absolutely. You see them walking around occasionally, to be clear, because
And
they
they're not happy. They're
no, of
not
course
happy
not.
campers. And
It's
so,
it's it's challenging. So understanding that, I come across it. I find this as an option. How do I compare it? Is this the best choice for me? What are the metrics? How does it stand up against the therapy? Because ultimately, I want the best choice as a patient.
yep. Well, that is a very good question. And of course, we have had many, many papers that were done by physicians on their own, not
Hmm.
sponsored by us. And the results are very indicative. They have the same exact results as Mohs surgery. So it's 99% cure rates. And we've had 5 to 10 years of follow-up now where it's less than 2% recurrence rates. So it's the exact same thing as Mohs surgery, provides the same outcomes, but without the scarring. The only drawback, and I don't consider it a drawback, it's treated like other cancers where you have to go multiple times. So 2 to 3 times a week for 3 or 4 weeks.
Hmm.
But again, if you include that healing time for those patients, it encompasses the same time, but their lives are not on hold. They can continue to practice their golf, their tennis, their swimming, their biking. And I don't know about you, but we're located in Boca Raton, Florida. Try to tell a 75-year-old that they can't do something.
Hmm.
Well, they're going to go out of their way to do it. Okay. They don't want their lives to be on hold. You can't tell them that they stop. They want to continue. So this becomes a very viable alternative for them and also for the physician, because there's a lot of complicated procedures that are go with Mohs. Lower leg, for instance, very, very difficult to heal when you remove a skin cancer from the lower leg, and the same with the scalp. And the reason why, your skin is very thin in those
Yeah,
areas,
very
it's close,
friable.
close
Yep.
to the bone, and therefore the blood flow really isn't there to help the healing process.
Yep.
So that's a problem. We've had many calls from people who are beta blockers that have to come off the beta blocker. The dermatologist will consult with the cardiologist. The patient will come off the beta blocker. We've had many patients that have gone to the hospital with a heart attack because they've come off the beta blocker. That's how serious the beta blocker is. And they call us immediately when they get out of the hospital. They said, I got to have SRT. It's the only way to get rid of my skin cancer because I just came out of the hospital after having a heart attack. So there's a lot of existing. And then the big thing that the doctors brought up to us is surgical fatigue. Many people have had multiple surgeries of skin cancer and they're just tired of it. And we had one patient that even said, they're taking me apart one piece at a time.
Yeah, no, it is. It is a challenging experience, and to be clear, we've seen nothing but increase. I mean, just look to Australia for their sort of approach to skin cancer, slip, slop, slap. From
Yep.
when I was living over there, they've really sort of addressed this because prevention is obviously the primary method.
Yes.
But as you rightly describe, and since you're in Florida, I mean, you just have to walk around
Yep.
to see the aged skin that's extremely exposed, and it's a straight line. I mean, I lived and worked in Australia for a while, and they were I would say ahead of the game. So clearly, new option, new availability. I mean, let's call out some specifics. I think you described 5 years of experience. That's the limit of where you're at this point. So it's showing good results comparably, but you're up to 5 years. Obviously, that will extend over time. So this is a genuine opportunity for choice. In the limited time that we have left, what's the story with the healthcare system here? And authorization. I mean, how does this compare, and what's the reality? Because we're all living that.
Yep. Well, the reality is Medicare covers it, which is great. We just received January 1st of 2026 our own codes. The physicians have their own CPT codes that reimburses for the patients. So there's no gray matter anymore. It's black and white.
Okay.
The doctors get paid for producing the procedure, and the patients don't have to worry about the cost of this procedure. It's all covered under Medicare and Medicaid, and of course, it impacts our seniors more than anybody else.
Right. So that's good news. What about access? So I go to a dermatologist. What does it take for him to be able to offer this? Is there capital outlay that he has to make? What can any dermatologist offer this?
Any dermatologist can offer this, and if we provide various ways of acquiring the equipment, whether they want to purchase outright, whether they want to lease it, buy it, or even rent it. So we give them every opportunity, even a shared service type of program. But literally, if they wanted to buy the machine, there's no money down. There's not a penny out of their pocket to begin with, and one patient a month is their break even.
So that's good news. So that lots of options for the dermatologist, but I'm pretty sure that you can't just drop ship it and off they go. What does it take from a training and education standpoint?
Yep, it's very easy installation, and we spend 2 days to 3 days training each physician on site along with their staff. We have a clinical team that goes out in the field and trains, and the training is ongoing.
So they can go
online. Yeah, they can go online, and all of the major societies and all the major trade shows provide training for the physicians. So they know about it, they have access to it, and it's very easy for them to be able to train as well as their subordinates.
Okay, so relatively easy for clinicians to step into this. They obviously have to be aware, have to understand it. I would assume that accessing the resources that you've talked about, probably available from the website, right? You talked about some of the papers, I assume published in relevant journals for dermatology. They just go to the website?
Yes, all recognized journals that have made the publications from very distinguished physicians who, quite frankly, weren't all in favor of this. But
shocking.
Yes, but needed the help. And so we're going through the natural process of getting into the market in healthcare. As we know, it takes a while. Again, I introduced positron emission tomography in 1999. It's still not mainstream.
No, it certainly isn't. So, all right, in the remaining time that we've got, wrap this up for us. I mean, to be clear, talking to somebody that was right there at the MRI innovation is, some would say that was enough, and then you went PET CT, and why this, and what are your thoughts about the future for this? Because that's a lot of innovation in the healthcare space.
Well, my motivation was my father, who was in his 90s, and he was, he had earned every one of his lesions spending time in his garden. in the sun.
I've not heard that. That's nice.
The last thing that I wanted anybody to do was to cut on them. So quite frankly, if you care about your mother, father, brother, sister, anybody that you know, this is a very strong, viable alternative that's going to cure the skin cancer in relatively ease time with no scarring, no cutting, and none of the problems of having the surgical procedure. But it also has help for the physician and makes them more productive where they can see more patients and be more of a consult for the patients, offering many opportunities. And it's much safer and easier for the healthcare system. The value proposition extends to them because there's no side effects. There's no extra payments.
Fantastic. Well, as we do each and every week, unfortunately, we've run out of time. Just remains for me to thank Berlin Media for sponsoring this session, and to you, Joe, for sharing the details of Sensus Health, the new option in town. I use new, and you can't see my air quotes on the radio, but new option in town for skin cancer therapy that offers people a new choice and changes the potential outcomes, I think, in a very positive way. Joe, thanks for joining me today.
Thank you very much, Nick. Appreciate it.